Good morning out there. Thanks for joining us for our second session in the genetics testing ECHO series. My name is Troy Jorgensen. I'm the program manager here at Project ECHO. And joining me this morning is Dr. Nathan Slotnick and Carrie Harrington from the Nevada Cancer Coalition. And I want to go around the group here as well and have you all introduce yourselves so we can know who you are and where you're at. So we had somebody just join us. UNR Med is the screen name. Could you introduce yourself?
I'm mute.
Yeah, let me take you off mute here. Go ahead, we should be able to hear you. Okay, maybe no microphone there, so if you just want to write in through the chat box. E. Novak.
Elizabeth Novak from Topeka, Kansas, and I'm a cancer registrar.
Great, thank you. Kat McPherson. Kat, go ahead, we should be able to hear you.
Good morning, everyone. I am Kat McPherson. I am an MSL in rare diseases with Amicus Therapeutics. Thank you for having me.
Thanks. And Dr. Robin Palmer, let's see if your microphone works.
Good morning. Can you hear me?
Yep.
I'm Robin Palmer, PhD. I'm a certified genetic counselor with Northern Nevada Genetic Counseling. Glad to be here.
Thanks so much. And last up is Mark Croshaw. Could you introduce yourself? Just a second here. Yep, go ahead. I can't hear you, Mark, so if you just want to write in through the chat box, that'll be perfect. So, Carrie, do you want to talk about your stuff first?
Sure,
okay.
Sure. Well, good morning, everyone. Thanks for joining us for today's Project ECHO series on genetics for healthcare providers. Today's webinar is specific to cancer as a genetic issue. As Troy mentioned, my name is Carrie Harrington. I'm with the Nevada Cancer Coalition, and the coalition in collaboration with Project ECHO is helping to provide this mini-series as an intro to genetics for our healthcare providers. Our coalition is a statewide entity, if you're not familiar with us, and we bring together organizations and individuals across the state to work on all things cancer, and we really work in three realms. We develop and implement cancer prevention, early detection, and survivorship initiatives. We work on policies surrounding cancer and increasing access to care for all. And the third component is providing information and education to the community, such as our online resource directory. We house the largest resource directory on all things cancer for everyone in Nevada. We also provide information and education to healthcare providers across the state, such as today's Project ECHO. So we're very excited to have with us today my friend and colleague, Dr. Nathan Slotnick. Dr. Slotnick is trained as a high-risk obstetrician and geneticist and currently serves as medical geneticist in cancer genetics risk assessment at the Renown Institute for Cancer. Dr. Slotnick also sees pediatric and adult patients in referral for genetic risk assessment and testing. He has numerous degrees. He is extremely intelligent and super smart, and that's why we love working with him. He has a master's degree in molecular genetics from the University of Washington and a doctorate degree from the State University of New York, Buffalo. As a medical geneticist, Dr. Slotnick provides genetic counseling, risk assessment, and testing to people at increased risk for hereditary cancers, which can assist them in making informed medical decisions for both themselves and their families. So without further ado, I'd like to turn it over to Dr. Slotnick. Thanks for being here today.
Thanks very much. My name is Nathan Slotnick. I'm a medical geneticist, and this will be my second, hopefully not my last, interaction with Project ECHO, and I'm hoping that we'll be able to expand this into other directions. About 2 weeks ago, we got together to talk a bit about basic concepts in genetics, and if you remember, we put together a bit of a historical perspective with the focus on Mendelian genetics, talking about how those very intelligent researchers back about 100 years ago put together ideas about how inheritance works. We also talked about relatively newer findings in non-Mendelian genetics. We talked about technology in the sense of how sequencing technologies have expanded and become more available, and how they become more interpretable and useful in a clinical realm. I went over in some detail the risks associated with next-gen sequencing and how misinterpretation can play a part in the realm of sequencing technology. We didn't spend any time on clinical application, or very little time, on the clinical application of the tools that we now have available. The clinical application part begins today, and we'll be focusing on specifics having to do with cancer. I hope you can see the title slide here. We'll be talking about genetics, genomics, cancer prevention and treatment. And I'll be focusing on areas that are right at the cutting edge of where we're moving with respect to inherited predispositional testing for both breast and ovarian cancers, as well as colorectal cancers too. Now, because I put the slide pack together a while ago, I can't right at this moment, and I haven't had a chance to look at it again, remember how this event will conclude. I don't remember my final slide, so there'll be a surprise to all of us, I think. So let's begin, and we'll begin with a true story, and I'll explain my interaction with this in just a minute. We'll talk about a particular patient. The patient, whose initials are LR, is a 52-year-old female with a recent diagnosis of advanced stage breast cancer, an invasive ductal form of cancer. It was found to be triple negative in terms of receptor testing. It was estrogen, progesterone, and HER2 new receptor negative. This is a type of breast cancer which is prognostically one of the worst. She had surgery. Her therapeutic options after surgery appeared limited. In an effort to determine the most reasonable management plan for this particular patient, a sample of this patient's cancer tissue was sent for analysis to a laboratory in Boston. I'll just say parenthetically, this is a patient who lived and was cared for in Ohio. Now, in Boston, what the laboratory did was to look at, in the tumor itself, 315 cancer-related genes and a number of different cancer-related DNA rearrangements. What was found in that tumor was a genomic change, a genetic change in a particular gene called the BRCA2 gene. Okay, so this was in Ohio, and because I have worked with and am a consultant with the company in Boston, the Boston company contacted me because the team in Ohio were unsure of the familial implications of the result that they generated, and I was asked to contact the clinicians. So I get on the phone with the clinicians in Ohio, and we talked a bit. The particular BRCA2 mutation was one at the time of 6,663 mutations that have been described in literature. We're now well over 10,000 particular DNA changes in this particular gene. This particular gene or mutation had been seen in previous studies and had been reported as being likely pathologic. I suggested to the clinicians in Ohio that they do a family tree, and if indicated, germline testing should be done. That is, inherited predispositional testing should be done. And what happened was there were 3 immediate family members who were found to be at risk for cancer development. They started surveillance on these 3 family members and not surprisingly, an early cancer was found. Now, this was a case that I was involved with, but it demonstrates in a number of different interesting ways how technology has influenced our ability to provide therapeutic choices for clinicians and patients that are based not on tissue of origin or the particular type of cancer, but on the genetics of the cancer itself. So let's move forward here. At the end of this particular talk, we should be able to have a discussion about the genetics of cancer. We're going to discuss the approach and management of the most common forms of hereditary cancer syndromes. We're going to talk about the hereditary breast and ovarian cancer syndromes. We'll talk about polyposis syndromes when it comes to colorectal cancer. We'll have a discussion about the hereditary non-polyposis colorectal cancers, also known as Lynch syndrome. At the end of the discussion, we should be able to identify and discuss the features of all of these conditions, have a sense of when to initiate referral, and appreciate the changes in the medical management and the purpose in the early detection and prevention. We may have time also for discussing other things as well, next generation sequencing, panels, things like that. We'll see how it goes. Now, the take-home message, even if you remember nothing more than this, is that cancer is a genetic disease. Now, cancer results from alterations in the DNA of specific genes within specific cells in the body. If the alteration occurs within one of the many cellular control genes, normal cellular controls are lost. That damaged cell then reproduces into a more control-less cell. A tumor develops because growth restrictions have been broken. Further loss of control results in spread away from the original cell's location, and that's what metastatic disease is all about. In a sense, then, all cancers are genetic because of the DNA etiology for those cancers, but not all cancers are hereditary. So I need you to think, or at least have a perspective of looking at cancer as a genetic disease, not necessarily inherited or hereditary, but genetic. And the image on the right indicates the general distribution of hereditary, familial, and sporadic cancers. Now, familial cancers, we know, have a familial context. We just don't have a good handle on the many, many different genes that go into the familial types of cancers. Sporadic cancers, familial cancers, and hereditary cancers have particular characteristics. Sporadic cancers are generally felt to be by chance and can be related to environmental insults and aging, which damage the DNA. As I indicated, familial cancers are generally felt to have many, many different inputs with several genes working in combination with environmental factors causing loss of cellular control, and the hereditary cancers that we had talked about already. The three particular breast cancer syndromes that I'll briefly touch on are these. The hereditary breast and ovarian cancer syndromes, most commonly associated with mutations in two genes, which I know you've heard of, called BRCA1 and BRCA2, is the first of the types of syndromes we'll talk about. The characteristics of this particular hereditary form of cancer includes breast cancer, occasionally found in women under the age of 50, ovarian cancer risk increase, male breast cancer can be found in this category as well, with associations with increased risk with pancreatic cancer, melanoma, and prostate cancer, usually in a younger age group than otherwise. There are two other breast cancer syndromes that I'll touch on. One is called Cowden syndrome, where mutations in a particular gene called the P10 gene are found. This is a condition where both malignant and benign tumors of the breast, of the uterus, of the thyroid, and of the skin can be found. and a peculiar findings called benign macrocephaly. Cowden syndrome patients have large heads. And if you ask a Cowden syndrome patient whether they had difficulty buying hats, you'll find that they'll look at you like, how the hell did you know that? For that reason, every time I see a referral for a patient with a breast cancer family history or personal history, I always measure the head of the patient and plot the head out. And usually you'll find that Cowden syndrome patients will have head measurements that are well above the 95th percentile for age. The last category of hereditary breast cancer syndromes include something called Li-Fraumeni syndrome, which is a result of mutations in a gene called the p53 gene. This category, relatively rare, includes very young breast cancer, frequently in the 20s, and childhood adrenocortical tumors, sarcomas of connective tissue and muscles, and leukemias as well. The p53 gene is associated with Li-Fraumeni syndrome, and of course, Cowden and Li-Fraumeni are named for the doctors that first described them. Now, interestingly, if you look at the BRCA1, BRCA2, or HBOC category of cancers, you'll find, and this particular slide doesn't project very well, but hereditary forms of cancer can be distinguished from sporadic or environmental forms of cancer. Usually the hereditary forms of cancer, the HBOC category, occur in younger people. There are associations with ovarian cancer and male breast cancer. There can be bilateral breast disease or multifocal disease. And interestingly, there are certain ethnic groups around the world which have been described as having increased incidence of mutations in BRCA1 or BRCA2. If you were to randomly select somebody off the street in Nevada and test them for mutations in BRCA1 or BRCA2, what you'll find is that about 3 to 4 per thousand will be positive for mutations. But if you look in the Ashkenazic Jewish community, the Eastern European Jewish community, you'll find that that number is not 3 to 4 in 1,000, it's closer to 2 to 3 in 100. And for that reason, every time I see a patient referred for hereditary risk of cancer, I always ask the ethnic background of that group. And it's not just a Jewish background either. There are other ethnic groups in China, India, and Africa where these mutations are found at a much higher frequency. Now, what does having a mutation in either BRCA1 or 2 do? Well, if you look at this slide, you'll see that by the age of 40, about 1 in 200 or 0.5% of women will develop breast cancer generally. But if that woman had inherited a mutation in BRCA1 or 2, that risk has gone up to 10 to 20%. By age 50, 2% of the female population will be expected to have developed breast cancer. But if a mutation in BRCA1 or 2 is involved, that number goes up to 33 to 50%. In a lifetime risk category, about 1 in 8 or 12% of all women will develop breast cancer, but with BRCA1 or 2 mutations, that number is much, much higher, 56 to 87%. But it's more than just breast cancer. Ovarian cancer risks are dramatically increased too. And as trained as a gynecologist, I can tell you that ovarian cancer is a very frightening type of cancer because it's frequently not discovered before it's disseminated through the body. In general, about 1.8% of women will develop ovarian cancer during their lifetime. But if mutations in BRCA1 or BRCA2 are found, those risks go way, way up. And that's an important part of the discussion with patients, both in assessment of risk and in management discussion as well. This slide is a little bit old. In general, we consider hereditary breast and ovarian cancer syndromes to take up about 80% of all of the genes that we know, but that number actually has changed a bit. We're now looking at BRCA1 and BRCA2 at about a 60 to 65% rate. There are many other genes that can be associated with hereditary breast cancer risk. In addition to breast cancer and ovarian cancer, a second cancer can develop as well. In general, if a patient has breast cancer and they're followed, about 5% of those patients, even with appropriate therapy, will develop within 5 years a second form of breast cancer. But a BRCA2 mutation will increase that dramatically to 12 to 20%. And lifetime risks of a second form of breast cancer go up as well. But it's more than that too. As I mentioned, male breast cancer, which is generally quite rare, is dramatically increased in incidence for BRCA mutation carriers, up to 7%. And in particular, it's the BRCA2 gene, which we think about. Prostate cancer, melanoma, and pancreatic cancer risks go up as well. And again, form a large part of our discussion. Now, again, this slide doesn't project very well, but you can inherit a BRCA mutation from either your father or your mother. That should be obvious from the discussion we had a couple of weeks ago about Mendelian forms of inheritance. So even though your father does not have ovaries, you can inherit a risk of ovarian cancer from him. And that needs to be considered and is sometimes not thought of as a particular issue in the counseling process. But it's more than that too. It's not, whenever you do a genetic test, you are, in a very real sense, not just testing the patient who's in front of you, you're testing the whole family. Familial implications of mutation carriage in families need to be considered whenever a test is ordered. And if you order a test of this type, you're obliged to reach out to family members with the assistance of the patient to make sure that testing for family members can occur as well. Statistically, if you look at families with BRCA mutations, you'll find that approximately 4 to 6 other family members are at significant risk as well. So family testing needs to be part of the consideration. All right. Now, there are things you can do if you do have a patient where these mutations are found. For breast cancer, we know that chemoprevention, including tamoxifen, can reduce risk of developing breast cancer. We know that oral contraceptives, birth control pills, by disrupting the pituitary ovarian axis, can reduce risk of ovarian cancer dramatically as well. So these two medications can be used in chemoprevention. Surgical prevention and risk-reducing surgery can occur as well. We know that bilateral mastectomy will reduce risk for breast cancer dramatically by more than 90%. We know that removing a woman's tubes and ovaries can reduce risk of breast cancer by 50%. Right? Again, removing the hormonal stimulus to the breast. We also know that obviously removing a woman's ovaries and tubes can reduce risk of ovarian cancer as well. And we do discuss when in the lifetime, at what age, these surgeries should be at least discussed and considered. This doesn't project very well, but this is approximately 3 years old now, but it lists the indications listed by the National Comprehensive Cancer Network on who should be offered screening testing, germline studies, and I've highlighted here other kinds of family histories and personal histories too. Prostate cancer should factor into risk assessment. Pancreatic cancer family history as well needs to be considered. So again, when you're doing risk assessment, you need to consider the whole of the picture in the family, not just breast and ovarian cancer risk. Now, we talked about the BRCA mutations, BRCA1 and BRCA2, but there's been advances in the last few years, 5 to 10 years in particular, about how we can think about some of the other genes as well. This particular patient, who's right here, presented to me, about 7 or 8 years ago. Her family history was rather remarkable. Both she, her mother, her aunt, all had breast cancer. There was an ovarian cancer in a grandmother, gastric cancer, prostate cancer, ovarian cancer over here. When I see a family tree like this, and as part of my usual approach to patients, you can use tools to calculate risk of patient developing breast cancer or having a mutation in particular genes. In this particular patient, I used a tool which was called the PEN2 model to calculate a risk for this particular patient. Her family history and her own personal history all brought together calculation of about a 59% chance of a mutation in either BRCA1 or 2. She elected to have sequencing and rearrangement of BRCA1 and BRCA2 genes, which were negative, but there was no mutation found. I was still impressed with her family history and personal history, though. And I told her at the time that I gave her this good news that things are changing rapidly, and rather than look at single genes, we might be able to provide her something more soon. I told her to call back in about a year, and exactly 1 year to the day, she called me back and said, "Is there anything new?" Well, at that time, a newer collection of genes, what we call a panel of genes, could be studied. This is, again, an evolution in sequencing technology. The panel that I use for this particular patient is called OvaNext, and it includes all of these genes, all of the genes that we know to have significant risk for ovarian cancer development. And there are many different panels that can be chosen for analysis. Each of the panels have different turnaround times. Many have different costs. Most are underwriter approved if you can make an argument that the risk for particular risk is high, and this particular patient certainly was. When the patient had the panel, this OvaNext panel, it was found that she had a gene mutation in a gene called RAD51C. RAD51C is a gene which works within the cell to identify and help the cell repair the naturally occurring mistakes that happen when cells divide. I'll get to that in just a minute. We do know that mutations in RAD51C are expected to increase the risk of breast cancer threefold, with a lifetime risk of breast cancer about 36% and a recurrence rate of up to 11%, and 11% risk of ovarian cancer too. Now, how do we think about this? Well, let me try to put it in this context here. There are, in an adult's body, approximately 30 trillion cells. All of those cells come from a single fertilized egg at conception, and it's very hard to think about how many cellular divisions it takes to go from 1 to 30 trillion, but you can be sure it's a big number. Every time a cell divides, there are 3 billion pieces of DNA or bases of DNA that need to be copied. We like to think that the copying of DNA in cell division is perfect, and that each daughter cell from a cell division is genetically identical to each other. But that's not true. We currently estimate that there are in excess of 100,000 errors which occur in DNA replication every time that a cell divides. Now, in a teleologic sense, cells don't like their DNA to change. There is evolutionary pressure to keep your DNA perfect and pristine. But sometimes that's not the case. So cells have evolved over evolutionary time a number of different systems specifically targeting the identification and repair of DNA replication errors. We currently estimate there are well over 20 different systems in the cell. And the reason, well, cells want to keep their DNA as pristine as they can. Now, one of the types of errors that can occur in DNA replication is the error called a DNA double-stranded break. The DNA polymerase in the cell tries its best, but occasionally a mistake right at the point where there's a double-stranded error occurs. And every time that this happens, a whole collection of genes get together with the idea of identifying, sequestering and repairing the error that happened in cell division. All of these different gene works together. Each of the different genes have a specific job to do in the replication. Now, you can recognize a couple that we've already talked about. There's the BRCA1 gene, there's a BRCA2 gene, and there's a RAD51C gene. These genes, when mutated, prevent the cell from efficiently repairing that DNA double-stranded break. By decreasing the efficiency, when mistakes happen, and they do, they're not repaired as readily, and mistakes will accumulate. And as mistakes accumulate, cancers can occur. Now, if you look on the right side of the screen, you can see that there are associations between breast, ovarian, and uterine cancers. The BRCA1 and 2 genes are right here, and the RAD51C gene is right there. So breast and ovarian cancer risks are increased as well. This just has uterine, ovarian, and breast cancer. So what does this mean when it plays out? Well, if you look at the general population risk for breast cancer, we've already talked about that being about 12%. A BRCA mutation increases that risk to over 50%. But a RAD51C mutation is kind of like a junior BRCA. The risks are increased, not quite as much, but still increased for breast cancer development. Ovarian cancer risks are increased as well. And that's I didn't want to go to this slide yet, sorry. Let me see if I can go backwards here. So here we have a demonstration of increased risk for breast and ovarian cancer outside of the BRCA1 and 2 picture. And it's a demonstration not only of how other genes can have a clinical manifestation, but also how gene panels or multi-gene analysis can really play an important role. Now, last week we talked a bit about the evolution of 2 weeks ago, next generation sequencing and how it's become a very important part of the armamentarium of those of us who practice genetics. But it also, I think we also covered how the cost for these panels has decreased dramatically. When I first got into this field, it was very difficult to look at any more than just 2 genes. The turnaround time for these tests were as much as 10 to 12 weeks. And the cost, the cost for doing these tests were as high as $6,000 to $10,000, frequently not covered by insurance. Nowadays, I can look at a 30 or 40 or 50 gene panel with a turnaround time of 2.5 to 3 weeks. And over the last 270 patients that I've seen, the average out-of-pocket expense for patients has been less than $40. So the cost for these tests has dramatically increased. But it's not just the cost that's important. We now have a much better handle on what to do with the information we can get by knowing the clinical implications, being able to make certain recommendations to clinicians for follow-up, and obviously extending that into the family as well. So just another example of how the newer technologies have really empowered us to provide more globally useful information to patients. Okay, let's turn to the colorectal cancer slide. We talked about breast cancer as having a relatively large hereditary component. Also is true for colorectal cancer or colon cancer. About 60% of colorectal cancer is sporadic. Just like breast and ovarian cancer, there's a familial component where many different genes and environments sort of play a role. If you look at the hereditary forms of cancer, they can be categorized into 2 categories: the polyposis syndromes and the non-polyposis syndromes. The polyposis syndromes are related to the development of colorectal cancer because of the uncontrolled development of polyps within the colon. The non-polyposis cancer, which is also known as Lynch syndrome, represents about 3 to 5% of all colorectal cancer and has other cancers associated with it too. So let's first turn our attention to the polyposis syndromes. There are many, and I've only listed 3 right here. There's the familial adenomatous polyposis syndromes, including two called Turcotte and Gardner syndrome, and it's something also called the attenuated familial adenomatous polyposis colorectal cancer syndrome, where polyps are related, also potentially associated with other cancers too. And these are related to mutations in the gene called the APC gene. Mutations in the APC gene prevent the colon from not maintaining control of polyp formation. If you have one type of mutation in the APC gene, your risk of colorectal cancer in your lifetime is 100%. Other mutations can give you other findings, including these two, and a lower risk mutation is called attenuated familial adenomatous polyposis with fewer polyps. There's another condition called Peutz-Jeghers syndrome where colon, breast, ovarian, pancreatic cancer, sex cord tumors or genital or gonadal tumors, gastric cancers, stomach cancers, and pigmentation changes. And I'll be showing you some pictures in just a minute. And then there's another form of cancer called the MYH-associated polyposis syndromes, which has a different genetics and a different gene associated, fewer polyps as well. Now, the diagnosis and therapy for these particular conditions relies primarily on clinical findings and the DNA sequencing results, which we can do. For the familial adenomatous polyposis consideration, these patients produce hundreds to literally thousands of polyps that are initially non-cancerous, but each polyp has a 100% chance of malignant degeneration. Polyps can develop as early as the 20s and 30s, sometimes even earlier. And there are other cancers associated as well: gastric cancer, small bowel cancer, pancreas, thyroid, and hepatoblastoma cancers too. This is a condition which is what we call autosomal dominant, meaning that you can inherit the mutation from your family with a 50-50 chance from the affected parent. Approximately 30% of patients with FAP have a negative family history arguing for a new mutation. And interestingly enough, and this is parenthetical, we know that women as they get older have an increased risk for obstetric genetic issues like Down syndrome and other chromosome problems. We talked about that last week. This is a condition where advanced paternal age can be associated with mutations in the APC gene as well. The gene associated we talked about is the APC gene. It's called a tumor suppressor gene. And this is what the colon of a patient with FAP has. This is a sigmoid colon where there shouldn't be many polyps at all, but polyps are everywhere. And the number of polyps in this particular patient exceeded by far 1,000 polyps. And this is what the polyp looks like under the microscope. They're a particular pathologic presentation. These are called tubular adenomas. This again is what the pathologist looks like when a biopsy for an APC or FAP patient would show. The pedigree for a patient with FAP is just as I indicated, an autosomal dominant pattern where a patient has a 50-50 chance of passing the mutation on to their children. 50-50 chance at each generation. The recommendations for patients with mutations in the APC gene include, and this is relatively rare for us geneticists, but starting sigmoidoscopy at a young age in a pediatric population, starting at as early as 10 to 12 years, or approximately 10 years prior to the presentation of colorectal cancer in the family, in other family members. So if you have a patient whose mother developed polyps of colorectal cancer at age 22, start about 10 years younger than that. You begin with sigmoidoscopy annually. You then turn to colonoscopy and annual until you get to the point of actually removing the colon. You need to do, because of gastric cancer risk, upper endoscopy and EGD studies at detection or at age 25 every 1 to 3 years. And remember, when you have a colectomy, removal of the colon, the end of the remaining 2 to 3 inches of the rectum will still be there. It's called a mucus fistula. That mucus fistula at the anus needs to be examined every 6 months to 3 years, depending on polyps there as well. That is, you're not removing the whole of the colon. You can't do that, but you need to pay attention to the mucus fistula as well. And you need to consider thyroid risks as well. For patients who have mutations in the particular gene, you need to remember that we'll do polypectomy as needed, preventative removal of the colon and of the rectum, and the timing of the colectomy will be based on the number and size of polyps, and we can do chemoprevention as well. Interestingly enough, non-steroidal anti-inflammatory drugs like Motrin do cause the polyp formation incidence and frequency to decrease, and there can be regression of those polyps as well. So Motrin is a useful tool until other surgical approaches can be provided. If the patient's APC positive, we talked about how to approach that, annual flex SIGs or colonoscopy, and if polyps are detected, treatment based on that. If you don't know the status of the APC mutation, you need to begin the flex SIGs or colonoscopies in this pattern until you can get the APC mutation examined. Now, there are 2 variants I touched on. I'll just briefly talk about them. One is called Gardner syndrome, which is about 20% of classic familial adenomatous polyposis, where you have colon polyps, but also soft tissue tumors and bony tumors as well. So if there's a family history of colorectal cancer, multiple polyps, and bone tissue, think of Gardner syndrome. There is something called Turcot syndrome, where colon polyps and tumors of the brain and spinal cord can be found as well, in particular medulloblastoma. So that part of the history needs to be taken too. Just to touch briefly on attenuated, this is a mutation in the same gene, the APC gene, but the particular mutation doesn't cause thousands of polyps, but fewer, but more than 10. Again, it's an autosomal dominant pattern of inheritance. 20 to 30% will be new mutations. And usually they're more proximal in nature. That is the ascending right side of the colon instead of the left. Risks of colorectal cancer are high still, even though you're having fewer polyps. And then it's usually diagnosis of colorectal cancer is usually in an older population. Peutz-Jeghers syndrome I touched on, and this is another condition with a different particular gene called STK11, which is a tumor suppressor gene. This is something that should be thought of every time you see a pancreatic cancer. There can be hamartomatous, not adenomatous polyps in the GI tract, increased colorectal cancer risk. There's an interesting finding of increased pigmentation on face and hands. Women have a 20% of risk of ovarian cancer. Breast cancer, lung cancer, and uterine cancers can be found. Obviously, there's testing available. And this is what a patient with Peutz-Jeghers syndrome looks like. Usually in a younger age population, freckling around the mouth, and interestingly, not just around the mouth, but on the inside of the mouth, including freckling of the gum and on the inside of the lower lip. So in addition to measuring the head size of patients who are referred, I also have them show me their gums and their lips so I can make sure that even though Peutz-Jeghers is pretty rare, I want to make sure I'm not missing something. The approach can be different. And again, the polyps that Peutz-Jeghers syndrome patients have are different as well. This is in the stomach, gastric polyps, multiple polyps, but of a different pathologic type than of the APC gene variant. Now, what do you do with polyps? Well, this is a decision tree, and this doesn't project that well. You look for the presence or absence of more than 10 polyps. If the answer to the question is no, you think about Lynch syndrome or familial colorectal cancer or other types of cancers. And your approach in diagnosis and therapy will be different. You look at the type of polyp. For FAP, attenuated FAP, and the MYH-associated genes, these are the classic adenomatous polyps that we talked about before. For the others, including Peutz-Jeghers and a couple of other syndromes like Cowden's, your hamartomatous polyps will lead you in that direction. So your decision trees are based here. Now, a lot of these decision trees were quite useful 10 to 15 years ago, but now since multi-gene panels are so available and so easily done and so inexpensive, it's often the case that we should just move directly toward sequence studies, next-gen sequence studies. Okay, let's end the discussion with a brief discussion about Lynch syndrome. Lynch syndrome was named for Dr. Henry Lynch, who I've met at meetings before, and I actually invited him to Reno about 6-7 years ago to give a talk, and it was just a wonderful opportunity to have him come out here, and he gave a wonderful talk on the history of Lynch syndrome. And he didn't call it Lynch syndrome, he called it hereditary non-polyposis colorectal cancer. And remember, we're talking about 5 to 8% of all colorectal cancer here. Usually found, not always, in younger patients, usually in proximal, the ascending right-sided colon, and there is almost always a family history of other types of cancers, including endometrial cancers, which is the inside lining of the uterus, ovarian cancer, pancreas, stomach, ureter, other. These are generally considered to be very rare forms of cancer. So other cancers will be part of your workup as well if you do a detailed family history. And this sort of points that out. In general, about 5 to 5.5% of all patients, all people, will develop colorectal cancer. But if you have a mutation in the Lynch syndrome genes, and there are 5, the risk of colorectal cancer goes up to about 80%. This is a little off. We're finding older population with Lynch syndrome too. Endometrial cancer, the inside lining of the uterine cancer, about 2.5% of all women will develop endometrial cancer, but a mutation in the Lynch syndrome genes will bump that up dramatically. The current recommendation for cancer approach and genetic analysis is that every endometrial cancer patient should have Lynch syndrome workup. Stomach cancer risks go up, ovarian cancer risks are elevated, biliary tree or liver, hepatobiliary cancers go up, urinary tract, brain cancers, the list goes on and on. So all of these cancers are tied to increased risk with Lynch syndrome. There's also the same kind of risk that we talked about with breast cancer. The chance of a second cancer goes up with a Lynch syndrome diagnosis. Within 10 years, colorectal cancer patients in general will have about a 3.5 to 4% risk of a second cancer, but a Lynch syndrome patient will have up to 30% second cancer risk. And within 15 years, the numbers are like this. So what do we do with Lynch syndrome? Well, we need to consider colonoscopy as a surveillance tool. And when a patient is found to have a mutation in one of the genes that we will talk about, you begin those colonoscopies early, and the interval should be less than generally recommended for colonoscopy in the general population. In the general population is listed here. Remember, we're talking about right-sided cancers as well. So in general, sporadic colorectal cancer, you start at age 1, 4, and 9, about every 5 years. But for Lynch syndrome, your recommendation will be much, much more frequent colorectal assessment, surveillance, colonoscopy, and certainly the consideration of colectomy or hemicolectomy with annual colonoscopy has to be. This is something that is being studied closely right now. The recommendations for colectomy or hemicolectomy are changing rapidly. We also need to think about the gynecologic cancers, ovarian and endometrial as well. For a patient who has gynecologic cancer risk, like the endometrial cancer we're talking about, we need to consider how to use the surveillance tools, which are in general pretty poor. Transvaginal ultrasound had a lot of promise about 10 to 15 years ago. It's not quite as promising as it was. An endometrial aspiration, or a brief small DNC of the inside lining of the uterus, can miss an endometrial cancer. You start early and you consider hysterectomy as a prophylactic risk-reducing procedure. This is a flow chart, but I put this together only to indicate to you the genes that are associated. We talked before about how errors in DNA replication are something that cells don't want to maintain. So as I mentioned, there are many different forms of error identification and repair. We saw that with the double-stranded DNA break slide that I had before. The genes associated with Lynch syndrome are different. MLH1, PMS2, MSH6, and there's another one here somewhere. These are the genes we know to be associated with the development of breast cancer. Those genes have a different DNA repair role in a condition called mismatch repair. If there's a mutation in a gene, the efficiency of mismatch repair in the cell goes down, and as we talked about before, risks will accelerate. We talked about next-gen sequencing last time. I won't go through this again in the same way, but I'll encourage you to go back to the slides that you can find, or the presentations on YouTube made by Illumina, which really detail nicely, and they're beautifully designed, how next-gen sequencing is done. And my last point is the same one I made last time we talked. The companies that are designed to provide next-gen sequencing for patient care don't exist for patient care. They exist to make money. So make sure that the company that is trying to sell you a product, that you understand how it is they do their work and how many different aspects of error possibility have been addressed. And don't have misrepresentation of this technology misinform you. I think that's my last slide. Oh, wait, this slide. This is my general approach to how I consider things like 23andMe and Ancestry and all the others. Just take a look at them. So that's pretty much it. We talked about a number of things in our two talks, going from Mendelian inheritance, non-Mendelian inheritance, and DNA sequencing, to the cancer predisposition risk and assessment tools that we currently have available. We talked about breast and ovarian cancer. We talked about other cancers associated with breast and ovarian cancer risk. We talked about colorectal cancer risk, both the polyposis syndromes and the Lynch syndrome, or the non-polyposis syndromes. And we talked about sequencing risks and benefits. And that's pretty much it. I'm happy, if you have any questions, happy to talk about them. Thank you.
Great. So any questions or comments out there? Comment from Dr. Palmer. Per National Comprehensive Cancer Network, RAD51C has unknown or sufficient evidence for breast cancer risk versus early evidence that suggested that it is. Among many of my peers, RAD51C is not considered a breast cancer gene, but do you know of recent evidence that indicates RAD51C is a breast cancer gene? And please cite it.
I personally have my own personal experience to suggest that it is certainly part of the consideration picture. Thanks for your question, Robin.
Any other questions out there, please feel free to unmute yourself with the icon in the lower left corner of the Zoom screen. *6 if you're joined by phone, or write it through the chat box. while we wait for you to think of some questions, did you want to talk about the summit?
Sure. Huge thanks to Dr. Slotnick for sharing this great information today and working with us on genetics through Project ECHO. And we also want to share out that the Nevada Cancer Control Summit this year is actually located in Reno, Nevada, the Whitney Peak Hotel, September 16th. We'd love to have you all join us, and you can see the link below, or you can just go to our website at nevadacancercoalition.org.
Alrighty, so we will be back with this same series in 2 weeks. We're going to have Dr. Susanna Sorrentino from the UNLV School of Medicine talking about neonatal and pediatric genetic screening. So that'll be on Wednesday, June 26th, 8 to 9 a.m. Pacific time. Same Zoom link and everything that you used to join us today. So hope to see you then. Thanks so much, everyone. Bye-bye.